Are we starting early? We still have 2 more minutes, I think, so maybe pause it. Thank you. All right, I'm going to go ahead and call to order the regular board meeting for the Seneca Healthcare District. Present, we have Ken Crandall, Rich Rydell, and myself. Absent are Sherry Paul and Shelley Stelzman. And let's please rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Okay, we will be meeting in closed session pursuant to Government Code 54956.9D1, conference with legal counsel, existing litigation, Velez versus SHD, Government Code 54956.9D1, conference with legal counsel, existing litigation, Robles versus SHD, and Health and Safety Code 32106. All right, that brings us to our public comment period. Do we have any public comment? Several of you received any public comment? We did not. Okay. And any hands raised online?
Nothing online.
Thank you. Okay, I'd just like to take a moment and thank all the staff for hard work getting the groundbreaking set up and executed, and thank Chelsea for doing such a wonderful job organizing it. And I don't know if any board members have anything else they want to add.
No, I totally agree with that. Excellent job.
I appreciated the golden shovel and the helmet. I keep threatening my wife, I'm gonna mount it above the fireplace.
All right, great, thank you. Okay, in response to public comment, we'll move along from there since we didn't have any. Next is number 6, approval of our regular board meeting minutes. This is for the minutes for the June 23rd regular board meeting. Do I have any questions, comments from board members? If not, take a motion to
So
approve.
moved.
Thank you. Do I have a
And
second?
second,
Thank you. All in favor, Ken?
aye.
Rich?
Aye.
And I'll vote aye. Thank you. Next will be our approval of our special board meeting minutes for July 12th. Any questions, comments, or motion?
I'll move to approve.
Thank you,
Second.
Ken. Thank you, Rich. All in favor, Rich?
Aye.
Ken?
Aye.
And I'll vote aye. Next up is our special board meeting minutes for July 18th. Questions, comments, or motion?
So moved.
Thank you, Rich. Second?
Second,
Thank you. All in favor, Rich?
Aye.
Ken?
aye.
And I'll vote aye. All right, next up is the Almero Foundation and SHD agreement. That's going to be on tab D. Board members had a chance to review. Major changes were made or are suggested to be made as we present this to the foundation, and bringing out the key component into the tab A, or exhibit A, exhibit A. So that would be the major change, and then also the agreement running from August 1st of this year, or whatever date you want to start it from, if it's today or tomorrow, through the end of August of next year. Any questions, comments?
This has to be approved by their board,
Yes.
and when does their board meet?
When is their next meeting? I'm not sure, to be honest with you.
Is it a monthly meeting?
I believe so, yes, they do meet monthly. I just not sure when it is.
Are they aware of the changes?
They knew we were looking to make changes.
Yeah, then just, along this, there's also in conversation. We passed the whole structure of the fee structure we passed by our legal, and they had some questions about a not-for-profit charging a non-profit fee structure. A fee structure, and they've never seen it before. We are talking to North Valley a little bit about, apparently the original one was based on some information from North Valley, but I'm not sure that North Valley knew that this would be applying to a non-profit or a not-for-profit organization. So we're getting some final language on this, but this is ready to go, if you will, to the Almero Foundation for review by the board as well.
Yeah, so basically, we're saying that we'll make a donation to them to cover their expenses related to handling cash donations.
Which is, yeah, just
Instead of it being
administrative
a
overhead.
fee,
Right, instead of a fee for the cash donation. They have the systems in place, so we would potentially make a donation to them yearly to help manage that administrative overhead for taking cash donations. Obviously, the non-cash donations play a little bit of different part in that, but we want to make sure that the cash donations themselves, since they have the system set up, that we're not paying each and every cent. I think that makes sense. We would, and for events, it's just the big part of the thing is for events, we would want a scope of work from them, outlining the numbers of people and the time spent so that we can reimburse them rather than the percentage of the donations at an event. We would pay them directly for their time spent.
Okay, are we geared up to accept donations?
Absolutely.
Okay,
In fact, we've already received a few direct donations through our 170B status. It's a little tricky because most people are used to giving donations to a 501c3, which is, from an accountant's perspective, is one of the easiest things that they do all the time. Getting to a 170B, which is what we are, it's not any more complicated, but it's just very rare. So we have on our donor page now, on all of our donor handouts, we have a complete rendition for their accountants to understand how to get it done.
okay. What happens if they don't act on that?
I would expect that if they review this and they wanted to suggest changes, it would come back to the board and we would decide whether we want.
So do we continue with our existing relationship?
Well,
during this
our
period?
contract is
And everything
expired.
comes into question at that point.
Our current contract with them is expired. It expired at the end of June.
Yes, so they asked for another extension, but we wanted to, as we've discussed in the past, we wanted to make some edits and some alterations to the existing contract. We talked specifically around the fee structure. I mean, so yeah, if they collect for us right now, they can't collect. We would stop being a fund until this contract gets completely executed. They couldn't collect on our behalf.
So what happens if,
They get direct. Instead of you can get directly, we don't have a contract right now, so we would not, until this gets executed, we would not be a fund and be under our foundation. So they couldn't by law collect. We had no
are
control.
they aware of that?
Well, I think so, because they were really rushing to get an extension.
I can understand them wanting an extension, but are they aware that if somebody were to make a donation, they're not?
We're not under contract with them, right? So that's why this needs to go to them to the contract.
I guess my question is, they understand that we would want them to tell them about how they could approach making a donation here?
That would be the next conversation. Knowing that if we cannot find an agreement here, that they may not overtly point in that direction.
So, we pass this now, how quick?
For review, and we might have a couple iterations come back. We didn't really change a lot of language in the actual terms and conditions. The only changes would be so really that's all we have to look at. Of the terms.
And if we were to have any substantive changes, they would have to come back to us. We can assume see it next month.
Give them time to edit.
I would assume this summer is the time where we do fundraising, right? So
Yeah,
this
certainly
is,
beginning.
timing is essential. I mean, really, gone for 6 months. So, I don't
I have
know.
my computer. I'm kind of gone, but I'm still available to work.
You're comfortable with the timing of this?
I am.
I guess I'm less comfortable with knowing that we're in
Well,
the
Because,
kind of,
because we can't receive direct
large giving won't
donations.
happen until, Q4 taxes are due still. But we've got till October, November, December. And I think we can certainly bring in a contract with them by that time. That's why it'll be to them and it'll be to the August board if everything's done by August.
Any other questions?
to.
Moving forward in the process.
Second.
All in favor, Rich?
Aye.
Ken?
Aye.
And I'll vote aye.
Okay, I will get this out to them right after. Thank you.
So let's move on to number 10, our medical staff report. We have a couple of reappointments for David Milkow, MD, BRAD, for 2 years, and Sergey Sergovich, MD, BRAD, also for 2 years. So do I have a motion to approve?
All those to approve.
Second.
Thank you. All in favor, Ken?
Aye.
Rich?
Aye.
And I'll vote aye. Okay, number 11, we don't have any policies and procedures to review for this month. Number 12, review of DBE contract status and sources of cash flow, both general conditions requirements. All right, do we have Donna? Yep, I see there's Donna.
I can barely hear you guys. Can you hear me?
We can hear you, yes.
Hear you.
Okay,
Microphones.
okay. So what this agenda item is twofold. One is the contract as it currently stands indicates that a GMP, a guaranteed maximum price, is to be developed at the time of 100% design development drawings. So we have completed those 100% design development drawings, and per contract should be putting together the GMP that solidifies the cost, the commitment. The Bolt has put together their price that they've put out to bid all the scopes based on the design development drawings, and are not recommending that at this point we do that, that we solidify the numbers, because they are not going to be able to solidify them at our 55.5. They, however, feel that if they get more time with developing the drawings and getting the bid process outside of the summer months where they're going to get more response, that they feel that that is going to bring us back into line with our 55.5 budget. So our request to the board is first, approval to agree that it is not in anyone's best interest to develop this GMP at this stage of the game, and indicate that per the contract, if it's mutually agreeable, we can redefine another time, another milestone at which to do the GMP. So what Bolt is suggesting is that they would be able to put it back out to bid in October and get better pricing, such that in November, being able to present to the board the GMP. In talking to legal, Seneca Legal has indicated that the board needs to know what the exposure is from a design perspective. This is not, so design fees have already been approved by the board. So we've got the notice to proceed for all of the design fees through permit. And so that amount exceeds what this number that I'm telling you now at 1.9, so 1,936,752 is the dollar amount for the design fees from now until what we're saying we would have as our proposed as the proposed timeline for getting the board the GMP. So that is the exposure from a design perspective, and the exposure from the contractor general conditions and general requirements that really, I've segregated. What you see in front of you is different. It doesn't have that dollar amount for the design. because what you see in front of you is what I'm asking for board approval to add as a notice to proceed for the contractor, general conditions and general requirements. So their staffing, their trailer, their fencing, their things such as that need to be on site. There's on site in order for us to proceed with our grading and drainage work that we're trying to get in place this year. So again, twofold, what I'm asking for the board to advise on is approval to move the timeline for getting the GMP at an exposure of design already approved, but to be spent at 1.9 million and change. And the second item that I'm asking for the board on this agenda item is approval for issuing the notice to proceed for the general conditions and general requirements at the sum of what you're seeing there in yellow of 1,066,270. So with that, I'll take questions.
Board members?
Donna, I'm sorry, I was really trying to track that, but I can't honestly say that I was tracking that very
Okay.
well. I'm just
Yeah.
wondering if you can reformulate that a little bit in condensed language. I know it's a big
Okay.
ask.
Okay. So the guarantee, so we have a contract with Bolt at a 55.5 target cost. In that contract, there is a requirement for a guaranteed maximum price to be finalized within that 55.5
At this period of time.
that is done via change order to that contract. The contract indicates that the timeline for doing that guaranteed maximum price change order is supposed to be at the end of design development of the drawings, which is what we have attempted to do. But because of the bid environment during the summer and the associated response to the drawings in a less than complete state, which is what design development is, it's not complete. They don't feel like they've gotten the coverage on the bid that can lead to them being able to do a GMP within the 55.5. So they, however, feel that they can get there if they're getting until being able to rebid in October for a November GMP.
Okay. That's helpful, Donna. Thank you.
Is it? Okay, thank you.
That's all. So it's just not enough bids coming in.
Yeah, they're high, not enough, and plus the final design changes some of the bid elements of it. So they're just asking for an extension to get to the GMP in October with a November approval by the board. So they can continue to, if you will, grind away.
We're just pushing back the timeline a little bit. Is there a financial jeopardy for us in doing that?
I don't think we're pushing back the timeline necessarily.
Giving
We'll
more
still be-
time for them to agree to the GMP at 55.5. They're working to get there, is what I'm saying. Is what I'm hearing them is they need more time to dial that down, to lock into that GMP.
And the exposure for the design, you know, and I'm discussing this with Grant at BBK. He said he wants to make sure that the board knows what the design exposure is from now until then. So that's that 1.9 million. So 1,936,752 is what Bolt has given me as the design costs from now until when they will have the GMP. But keep in mind, again, those dollars have already been approved by the board. It's just that they will be expended is what we want to make sure that that's clear in your decision.
Questions, Rich?
No.
Okay. So I think that's very clear, Donna. I really appreciate that. Well, I had a few other questions, but one of my questions was around our interim financing, because we talked about cash in as well as cash out. So when do we anticipate starting to see an influx for our temporary financing?
Let me pull that up. Bear with me here.
Sure, thank you.
So we have,
Seeing flowing in.
Mhm.
Yeah.
Yeah.
I know that name on the top of my head. I don't know.
we have, based on, input from Fieldman Rollout, we have a, funding coming in October, is what I'm showing on the cash flow is for the inflow. And before that, we are looking at, so through September of this year, we're looking at having fully expended, from the beginning of the project until end of September. So incorporating what's been spent to date plus the forecasted through September, we're looking at approximately 5.2 million. And then having an influx of dollars in October of 29 million. Of 29 million.
Okay.
And
Thank
we've
you.
got that, and we have that resolution for payback too, to
Yes.
reimburse ourselves, right?
Yes.
So outflow till October.
Yeah, that's what I wanted to know.
Yeah.
And, oh, Steve just walked in.
Yeah.
How did you know you were, I was gonna ask you next, Steve. So we're talking about the,
I was listening.
Okay.
Yeah.
yep. So from your perspective, how do you feel we sit as far as with these dollar amounts, with these timings for when they hit?
Well, we're not getting interim financing in October. That's a
Okay.
given.
Okay,
Oh.
why is that a given?
Because we will, if we're going through the USDA, their approval would be sometime in September.
21st-ish.
And I think that's probably, what's the word? Optimistic turnaround time of October.
Okay.
So,
Okay.
yeah,
And do we have to wait for that approval in order to issue the interim? We do. Okay,
What they say, Steve, what's the time spent, once the application's approved? Was it a month or 45 days? Did they say 45 days?
yeah, they'll submit it the middle of August and with a tentative approval sometime in September.
And after that, we can go with our interim.
Well, then they'll give us a letter of conditions.
Right.
And they seem to think that there was some work for us to do there before we could.
what kind of conditions, like, just as an example?
I'm trying to think for our project what they would say.
If you don't have one, that's fine, I just was trying to understand it.
I guess they would ask us to have some administrative pieces in place so that we would have to,
Some reporting to them about progress.
and then have a mechanism to receive the funds, distribute the funds, those types of things.
Okay,
Counting.
and allocate them to the specific items that they're allowable for. Yeah, okay.
Um,
So then,
we will know on Monday, we can talk to them, we have a meeting with them Monday, the 31st. And we can get a sense of what the conditions might be, how long it would be. We can also tighten up the date on how long it would be for an approval. And inflow.
so do we expect be able to see an influx before the end of this calendar year?
I would say that that's not unreasonable. No.
Okay. And how comfortable are you with that?
Pretty.
Ready? Okay.
Yeah, I think from what we've seen recently with the correspondence, Whitley is updating their forecast. They'll have it on the timeline we had to get the forecast to them a week from
amazing.
tomorrow. They'll have it by then or sooner. So I think everything's on track. The environmental stuff seems to be doing well. The information Donna's been submitting for the PAR, so I think we should have a complete package to go.
So the exact date for, interim financing, the inflow is what we're really focused on, is our cash flow out.
Right.
And when we can expect inflow, I would expect before the calendar year, definitely.
Okay.
Do you agree? Before we start having that interim financing coming back in.
Say that.
So our outflow is not going to be about $5 million up till about October-ish, right? About 5 million total year to date on it. Our outflow, paying for things until our interim financing comes in, we get our first inflow of money will be before the calendar year.
Yeah, I think the biggest concern is the outflow from now. So what we spent today, we're covered. So it's how much are we going to expend from basically today until we start to receive the interim financing. And so all I've heard today is that the completion of the design and these general conditions.
Correct.
Donna, it sounded like you said a 1.6 million and a little over $1 million.
1.9 million in design and $1 million, just for rounding, say 1.1 million for GCs. That's adding the 2 yellow items on within the board packet of the GCGRs. So 1.1 million for that and the 1.9 for the design.
Right. And
Do you want to table this for the moment? Is it?
If we can move through it.
Okay.
then-
Yeah. Well,
So I don't know, just thinking about what the options are limited, just speaking frankly. If we can have them proceed with the design, and we will be proceeding with the timber and the grading such that we need the GCGRs approved. Or I think the other option is really is not a good one. I mean, it would be to stop after the timber harvest and understand that we're looking at that delay and have them rebid the design development documents, which would still be as they are now, as at the level of completeness, but just get the benefit of a different timeline of the bid being in October.
yeah, no, can I interrupt for just a second, Donna?
Yeah.
So Steve, with this change, it's not that we're anticipating having these expenditures and the inflows hit at a different time. It's just that we are having the finalized GMP deferred till later, as my understanding, right? So where we're paying for things, where we're getting our interim financing coming in, none of that's changed, right? With this,
No, with this,
yes.
so Donna, you talked about grading. What amount of grading is involved in the $1.6 million or any kind of site development in the $1.6 million and just over $1 million on the general conditions thing?
That is a very good question, because that does not include grading. It includes the oversight of the grading, but not the grading itself, because you'll recall that we're looking at pulling that scope out of the Bolt contract. And so we're getting the costs of that by bidding it directly out, and Grant is working on that paperwork. But I don't have the cost for the grading itself on top of what I have here for the Bolt contract.
Okay, so if we rolled all this up, so out of pocket, completely out of pocket, owner's contribution, year to date and up to, say, November, let's include grading, what does that aggregate cost? If we include the grading and we include these things, what does that outflow look like until we can expect our inflow, our first inflow of interim financing, which we expect to be the first year or before the calendar year?
So I can answer, so that I'm sorry.
Go
Say
ahead.
Okay, so the number that I gave previously at the 5.2 million is inclusive of grading. But keep in mind that when I get, and that's through end of September, when I move on to the next quarter is where I hit a challenge with giving you more detail, because I have it broken down by quarter, not by month. And so what I have until the end of the year adds another 5.5 million to that 5.2 million.
Okay, and that's in total, but what is that minus what we've already outflowed? So how much more from now to the end of the year in total, including the grading?
So our so for this quarter, July through September, and next quarter, October to December, we're looking at 7.4 million.
Still outstanding.
On top of what we've spent year to date. So that, go ahead, Donna.
Yeah, so not including that amount. So we've spent to date 2.8 million. And these for this quarter and next quarter, if we were full steam ahead, it's actually 7.5 if I round, so 7.5 million additional.
Almost 10.
So to make it easy, I guess, on everybody, what I'm very comfortable with is proceeding with the design, pushing the timeline out, and the general conditions today. I think we can absolutely commit to that financially and move forward.
Okay, you need a motion? I'll give you a motion.
Sure, thank you. Thank you, Steve. Thank you, Donna. Do you have a second?
I'll second.
All in favor? Rich?
Aye.
Tim? Okay, and I'll vote aye for deferring. Do we need to include the motion to say that we're deferring the GMP to November? And we're issuing the notice to proceed for Bolt, for the general conditions?
Yeah, I'd feel much better if we both make that specific motion and cite the amount that's included in each of those pieces.
Okay, so cite the amount included in each of which pieces? I'm sorry.
From what I understood, the design
And
the continuation of the design was the $1.6 million something.
1.9.
1.9. And then the remainder through.
The general conditions.
The general conditions are a little over $1 million from what I've seen.
Yep, $1.066 million.
Okay. All right, so then can I have an amended motion to defer the GMP to be developed in November,
So moved.
presented at our November meeting with design of 1.9 million through that period and the general conditions of what we're presented here today, which is just over 1 million. Yes? Okay, thank you. And second All in favor?
Aye.
And
Thank
Ken?
you, Steve.
And I'll vote aye. Thank you. Okay, thank you, guys.
Thank you, Donna.
Thank you, Donna. We are going to skip down to item number 6 for the moment because we have a guest speaker with us today. 16. I'm sorry, 16, thank you. This is the Chief Health Officer from Oracle Health. Doctor, if you wouldn't mind announcing yourself, I don't want to say your name wrong. And
No
welcome to our,
problem.
welcome
Hi,
to
everyone.
join us.
Good afternoon, Nassim Aslar. I'm the Chief Health Officer at Oracle Health, and I'm joined here by my colleague, Dr. Michelle Fleming. Michelle is our CMO and market leader for our Community Works group of hospitals, of which you are one of. So we are thrilled to be here. Rich, I don't know if you want to give a lead in, or if you'd like me to talk a little bit about some of the changes that we've gone under with Oracle Health and what we're looking at, and then I would love to answer any questions that you all have.
Yes, please.
Wonderful. Just a very quick background on me. So I'm an internal medicine trained physician. I practiced as a hospitalist for over a decade here in Southern California at UCLA Health, and I was in C-suite positions on the delivery side for about 16 years, and initially in quality and safety, then population health management, health system contracting. I ran for about 3 years, bringing value-based products to market. And then in Chief Operating Officer role until I joined Cerner in January of last year. And then we were fortunate enough to come under the Oracle family in June of last year. And I've been with the organization now for the past year. When I joined Cerner, and I'm gonna ask Michelle to give some more history and background. So please feel free to jump in, Michelle, where we should dive in a little bit. But when I joined Cerner, one of the things that was clear as I spoke with our healthcare delivery systems across the country is that there were some really key pieces that were missing from the electronic health record as we were looking at how can organizations be successful in really delivering the quintuple aim. This, I can tell you, coming from the other very large electronic health record system, is something that's lacking across the board in the healthcare arena. At the end of the day, healthcare has gotten far more complex over the last 2 decades. I always remind our team, when I got out of training, no one knew the quality of care I delivered. No one knew my patient experience. No one knew what the cost of care was. There were far less regulations than they are today. Thankfully, we now have all of these elements, but we have not been clinically led and IT enabled in coming with solutions that help address these broader pressures in healthcare. The acquisition by Oracle was really to give us that the resources and the ability to be able to address not just where healthcare is today, but really where it's going in the future. And I want to just break that down for you all into 3 major categories that I think about. The first one is just the electronic health record itself. Again, it's a tool, and I'm old enough where I practiced on paper and pen and underwent the transition with EHRs. It's a tool that took our workflows that were not optimal on paper to not optimal electronically. Again, the amount of information in healthcare, as you all know, has changed exponentially. Our accountability has changed fundamentally, and our tools need to adapt to that as well. So priority number 1 for Oracle Health has been, how do we actually get you the right tools so that you can be successful in care delivery? Priority number 2 is the electronic health record is one part of the broader ecosystem for healthcare. So in a healthcare delivery system, we have a very complex business where we have significant amount of human capital management. We have massive supply chain issues. We have a lot of resourcing that we need to coordinate. So if we can actually leverage that clinical data along with everything else that we need to do in healthcare and have all of these systems connect and go from silos of data to an intelligent system that proactively enables you to know what your census is going to be like. What are the types of supplies you need? Do you have the right people with the right training at the right time at bedside? That can enable us to move forward into where the future of healthcare is going. And so that's level 2 of what we're working on. And we're working with a couple of healthcare delivery systems to really prove out this concept of connecting all of these systems into a system of intelligence. And then the last part is there is a broader ecosystem of healthcare that we need to coordinate and build so that we can successfully deliver for our patients and our communities. So for example, how we interact with our payers currently, and again, I've been talking a bit from experience in running health system contracting, there's a lot of friction between, let's say, for a very mundane, everyday thing that we do, getting prior authorization. We have physicians and our caregivers spending a lot of time filling out paperwork, still to this day, faxing information back and forth, getting denials because we didn't have enough information in order for us to get a prior authorization approved. We're working with payers around how do we really create a seamless interface there so that we can auto-adjudicate the majority of claims because we have enough data to be able to know that this is a claim that should go through, so that from the time the physician puts in that order, when he or she is meeting with the patient in the clinic, to the time that patient walks out front to schedule, that claim is actually auto-adjudicated and we can go ahead and schedule and really enabling access to care and eliminating a lot of the gaps that we see in care. So this was kind of a high level view of what we're thinking about and where we're going. Michelle, what did I leave out?
I think you left out nothing. I was going to speak to the fact, and hello everyone, Michelle Flemings. I'm an ER doc by way of, hospitalist before the word existed back in the 80s, and intensive care because, well, I was living in New York City and I loved to get really nice little shoes to go out to the disco, talking about my age. So I needed a part-time job. I found that and I found the ER and decided, wow, I love the fact that stuff happens and that I can have an immediate impact and hopefully on the patient's worst day, make it even a little bit better, sometimes miraculously better. I have been in this position as the CMO of Community Works now for about 1.5 years, 2 years. I was a client before. We were client number, I think, 42 at Pagosa Springs Medical Center signing on for this delivery model. So I know it and I've watched it grow and I've played with it and I've helped it to mature and I've helped it to really get better in a lot of ways, including some of the things that you guys are experiencing now. In my position, I'm the physician strategist. So all things clinical go through myself or through one of my nursing teammates before it comes to the workflow. We're also included in the roadmap. And anytime anybody has a, how do you do this kind of question, we're the ones who help to figure out how do we do that in a very simple, intuitive, and non-frustrating and non-disruptive manner in the EHR. So what I do is I also work with clients as needed to help get adoption, to help with improvements with regard to the physician satisfaction if there are issues, because we also know that a lot of folks get dragged kicking and screaming to an EHR. And I dare say if you don't have any, you'd probably be the first of all of our clients to say so. But happy to meet you. Do you guys have any questions? I think Naseem covered everything about the transition to Oracle.
Go ahead, Rich. I have a few questions.
Well, I think
Sure.
we're Critical Access Hospital, which you know.
Us too.
And our team, and our team just went through implementation and have had some issues. So I'd like our CEO and CFO and CNO to be able to ask you questions. I think you can start about the domain if you want to.
Yeah.
Okay.
Yeah. Dr. Fleming, thank you, both doctors. I appreciate it. You know, I come from, I have a pretty strong IT background as well, and I've done a lot of implementations in electronic health record, including working around Millennium. You know, I worked in and out of Millennium multiple times, and I've taken a look at the two products. You know, I think that the Community Works is great. I think it's great. I wish it would mimic Millennium a little bit more. There's some things in Millennium that are very useful that for some reason just don't appear in Community Works. There's some physician experiences that are in Millennium that aren't in Community Works. So I'd like to see more alignment between the base product of Millennium and the Community Works. The other piece is domain compatibility or domain similarity. You know, we have domains that have more functionality than our domain, and I wonder why. It's all, you know, the Community Works environment is really built for smaller hospitals. Now, we may be smaller critical access than one back east, but that doesn't mean that we do not need the same things in our domain that they have already in their domain. So we're finding these things out. I think that domain similarity is really important, that we don't have this disparity. We've learned from a Community Works client back east that they're able to do things in their domain that we simply cannot do, which would be very beneficial to us. I do want to go back to the comment earlier about analytics and predictive analytics.
Yes.
And the data, these data that we are trying to build into that triple or like say quadruple aim to hit those things. They're as important to a small critical access hospital as they are to a large entity. Absolutely 100%. In fact, I would say more so.
I'd say even more important.
Yeah.
I agree.
Because we are walking the thin line constantly, and the more analytics and predictive analytics we can see from a business perspective or a clinical perspective is hugely beneficial to smaller facilities. So we are going, and we have yet to do our health check and get some of our lights on stuff going in our GA2, but we're looking forward to that. But I agree with your philosophy. Last one, if I might add, is the implementation methodology in Community Works has a lot to be said for it. There's a lot of work there. I know we were one of the first when you went to S&P as your consultants in implementation and conversion. And there was it was really kludgy. And as a PM by background, I know how projects are supposed to look. It was a tough role for us. It was tough. The biggest one where we built in production and then copied to a domain or to copy over to build to do our testing is a little wonky for me. But the biggest thing was we build with the DCWs in production. Then when they copy to the build domain, the build to do testing, we lose so much data in that conversion.
Wow. Okay.
We rebuilt our DCWs no less than 3 times. And that's tough. So anyway, I'm done.
Sure. Well, let me go back to number one. Number one is it's all Millennium code. The difference between Community Works and for quote traditional or big Cerner, like folks like to call it, and I've worked in both and a lot of iterations of both, is first off the cost. The traditional costs a heck of a lot more, and for that you do get the ability to do almost anything you want to do with it. To the point that some places where I worked, it wasn't until after I had been in there that I went, wait a minute, that was Cerner, because it's so different. I will agree with you. Yes, there are certain things that you can do in traditional that you cannot in Community Works, and some of the playbooks. Some of the playbooks we actually are having discussions about already with regard to, when I say playbooks, everyone, it is, if I'm a GI physician, there's a certain portion of how the workflow looks because it's me as a GI physician, as opposed to what, say, an OB or a cardiothoracic surgeon would want to see. And some of that is purposely done, and because, again, critical access hospitals and cardiothoracic surgery don't typically mesh. But we can talk with you about how to make it emulate much more of what you're doing, because we are little as well. We're critical access as well, but we also have ophthalmology, we have OB, we have orthopedics, we had neurology, we have oncology clinic. So yeah, it's not the run of the mill primary care, ED and inpatient. There's a lot more to it. So we can talk with you as well as with your CAE and figure out how best to get what you need in there. I think that's number one and part of number two. You also spoke about S&P. I've honestly not had experience with them, and for the fact that they put you through stuff that didn't make sense and caused extra work, I apologize. I will definitely make certain that our consulting team knows about that, so that way, if they are up in line for another opportunity, we make certain that doesn't happen to someone else. It might be a matter of familiarity versus not. Yes, sir.
Let me be clear. S&P, they're not bad. I think we got caught up in the conversion, the transition from the Oracle or the Oracle implementation.
I see.
So I think there's a little bit of a timing thing, but the thing that was really disruptive for us was the methodology on the Oracle team side of building in prod, copying to build, and the drops. So I think that might have been an Oracle engineering thing. Okay, I'm done. There we go.
Fair enough. No, I'm psyched that you're using your nerd brain on me. That's awesome. Challenge of my nerd brain. That's really cool. And I will admit, after we went through those 2 or 3, I've now forgotten one of them, because I know you said 4 things. You said selectivity, domain similarity. Thank you. Yes, there are certain domains, and there is one, if you're talking about domain F, as in Frank, there are some East Coast hospitals in that do have different functionality, partly because they're larger hospitals. That notwithstanding, though, there are ways of discussing with your domain what else we need to do. The hard part there is going to be, how do you build it with not breaking everybody? And also with the way that the votes go, and I know we suffered from this. We were in domain C, so we were the 3rd domain to go live. We suffered with this when we were trying to get bigger, and a lot of the ones back then in domain C were like, no, we really want to stay small, and we don't want to have to deal with this being in the build, and we don't want to have to deal with making certain it's off or putting it off to the side so the docs can't see it. But again, let's sit down, you, me, your CAE, and figure out, where do we need to go? How do we take this through the global change process? And if it's not a global change, maybe it's something that we can potentially turn on in just yours. But let's talk, okay? Rather than have you sit and wonder and not be happy.
Yeah, because I think some of the items you said were just grayed out in our domain. It was, you could see the functionality existed, it just wasn't available.
Yeah, it was dithered.
Yes.
It was just dithered out in our domain, and we couldn't use them, but we need them. So, once again, we're not beating up our Cerner implementation. I've done multiple implementations. I think went very well, frankly, because I'm not unhappy. We're not unhappy. It's actually a better system, and our team very, very hard, and S&P stepped up. But just little things that I noticed that might be tweaked to just improve the next person's experience.
Sure. Well, let me ask this: the functionality that you're looking for that's dithered, if you guys have a list, we can even start going through that before we even have to sit down and see why not. Okay, or how we can. How's that?
Well, I'll tell you that we're already starting to undither some of them. So
great.
We're
the de-dithering process. Very cool.
Yeah, we're erasing the dithers. Yeah.
There you go. And you said your CNO was at the table?
Yes, she's right over here.
Indeed. Madam CNO, I serve at the pleasure of my charge nurse always. What do you have on your list?
I would have to echo a lot of what Sean went through as far as the building of our DCWs. When you're such a tiny facility and you already have working managers, and this was very labor intensive. So
yes, ma'am.
It was actually, I mean, I had managers that were basically in tears going, I have to rebuild this again. Where did it go? And it didn't seem like it should be our responsibility as the tiny hospital to figure out what went wrong on the other end. It should have been Cerner or whoever really looking for what broke before we're asking them to rebuild a 1,500 line spreadsheet. And
Yes, ma'am.
so that's what we're asking. Please look into these processes of how these breaks occur so that another tiny little facility like us doesn't lose all of these man hours. And there were times when I thought our lab manager was just going to walk out, get on the Pacific Crest Trail, and we are never going to see him ever again. He just was that frustrated.
Yeah,
But
no, I can only imagine.
we knew that this, I've been through other EHR implementations as well. Just my first time was Cerner. We knew that we would uncover the skeletons in the closet, and we did. And in that regard, it's been a very positive thing for us because we are getting things, processes in line and straightening some things out, forced us to look at our formulary, et cetera. So in those regards, it's been a very, very positive thing. And we knew it would be. We knew we could use it leverage it as a change. So in that regard, it was positive, but the breaks in the build to production and back and forth were beyond frustrating and should never happen. They just shouldn't happen. So that's really all I have to offer. I think
That's a lot. And I agree
workflows-
with you. It shouldn't take away from patient care and the other duties we all have to do.
Yeah, I love it. I get onto Cerner. The very first thing when I come in every morning, it gives me a great picture of what's going on. I'm really looking forward to learning about the reporting features and our KPIs and all of those. And that will be coming very shortly. So, and we just hope that the data that we're entering will come back out to us the way that we are hoping that it will.
Indeed. Yes, ma'am. Yes, ma'am. And to that end, what we're also going to need to know immediately is if we're pointing at apples and you're pointing at pomegranates. Just because they're red doesn't mean that we're measuring the same timestamp. So if you're noticing those, especially early on, let us know so that we can make the proper changes so that the data that you do receive reflects what you want it to and what you understand it to be and what you need. Thank you.
Yeah, the CFO's last, huh?
CFO. I was raised by nurses. I apologize, not really, but I was raised by nurses. They say I can, therefore I do. Go ahead, CFO. Yes, sir.
You can't make it through the day without your nurses. So
That's right. And an ER man. No.
same on the wards.
That's it. Yes, sir.
So this is kind of for both of y'all.
Yes, sir.
It was kind of driven into us that kind of Cerner's mantra is clinically driven revenue cycle. And I get it, I see it now. But one of the issues with small critical access hospitals is that is an entirely new concept to us.
Yes.
And when we did the implementation, the implementation, for lack of better words, were kind of done in silos, where the clinical people worked with a separate group and they met with their SMEs and all that, and then revenue cycle, patient accounting, and finance was in a separate group. And that certainly may work okay in large organizations where there's already a revenue integrity function, and you talk about charge nurses and things like that, where someone is already on top of it and is attuned to it. Clinical people do clinical work and there's administrative people handling that. but at our hospital, our clinical people are it. And so it's a whole new learning experience for them. And we kind of forced our way into their groups so that we could see how are they doing their build, and literally finance came over and did the integration testing. And so we could see the build and we could see that information. But I think as you guys start to continue to work with smaller facility, and thank you very much for making this available to us, because this opportunity did not exist. I think back 20 years ago when we put out RFPs for information systems, woof, there was nobody in it. There's been a progression where more and more robust systems and vendors have gotten into the mix, and now with you guys, with a product that serves critical access, that's a tremendous opportunity to us. That this is something that's going to have to be ingrained in the implementation and training, because what we're doing now is we're going in and through our charge reconciliation function, which was really not rolled out to the clinical people in much depth, we're now training them on the revenue cycle piece. And fortunately, you know, they're engaged and they work with us, and it's become a very successful function, but it's something we completely missed. And one of the other things that's very frustrating, and I'm probably saying it a different way than both Sean and Judy did, is that we are still building our system in the live environment. And that's not significantly, I saw your eyes go, but we're still setting SRs. We're making changes to charge service. They're building additional charges. Care sets were overlooked. Certain things were overlooked. And that's really a big thing, because that's been one of our downfalls, is that the physician training, and part of it's on us because the nature of our physicians, they're kind of nomadic, and then they come in and they work and then they leave and they come back. And so it's not like they're community, all of them are community based, where we can bring them in on their off day and train them and things like that. So that building of the care sets was so critical, so it was easy for them to go right in there and find it and not have to fumble around, and then not give up and say, well, I used to just do this in paper, coding would catch it, you know, all these things. But we're getting there. But I think the big thing is to realize in small organizations that that almost everyone needs to be in the same room when you do such critical things like you know, build your system. Yeah. And how the you know, from day one, the clinical stuff worked. There's no doubt about it. When we turned it on, you know, patients were cared for. There was no disruption in care. That was fabulous. I mean, that's obviously, even the CFO, that's my biggest concern, is the ability to do that. But again, now we're working through it, and we're getting there, and we can see it. We can see how it's going to work. We can see its potential, and that is a truly rewarding and exciting part. So
on the side, thank you for developing a product that is for the smaller facilities. You know, once again, that was a void out there. There was nothing. So thank you for doing that. I think that it's an evolution. You're going to do great stuff in the market. I can tell you, just if you just continue to tweak it. I mean, we've got 3 other hospitals around us that are part of our core 6 hospitals around here. They're all moving to Community Works on the same domain. Yes. Okay.
Wow.
So,
wow.
I know, right? So no, it's a great product. It's just tweaking the little things, making the delivery a little different. That's all. But thank you for having the CCW, the Community Works.
Yeah. Thank you, though, for the candid feedback. We'll definitely take that to the powers that be to make certain that they benefit from your feedback and take it to the next place.
Well, we thank you both for joining us today.
Yes.
Appreciate it very much, and hope
Thank
to
you
see
for
you both
having
in
us.
Ohio.
There we go.
Really appreciate your time. Thank you for listening and being a great partner. So we really appreciate it.
Thank you for all that you do on behalf of patients and the community. we are truly grateful for all the hard work that you do. We are here with you in partnership to continue to make this easier and more effective as we move forward. So we really are grateful for the opportunity to catch up with you all. Thank you. Thank you.
Thank you.
Thank you. Have a good evening. Bye-bye now.
Thank
Bye.
Okay, great. Anything else on that? Alrighty, then I think we are going back up to our signage bid number 13. Donna, are you still, yep, there you are.
I am, yes. All righty, so we had put the signage bid out for RFP and received the responses back, the proposals back, as are included in your packet. We did receive 4 back, and we've put together the bid comparison to evaluate them. When we look at the 4 bidders, we've got Weidner, Take Form, Shannon Hackley, and New Group. And we've got 2 that I'm proposing that are thrown out. One as a high at 607,000 on a 607,000. I'll just leave it at that. And then the low that we have is I would like to propose that is not a responsible bid, as it does not have a reference to even all the code signage that is non-negotiable.
I was going to ask about that, Donna. Plus, I think that bid also did not include the installation cost. It just had installation overhead, right? Or
It had I believe that their signage cost was inclusive of installation, but that did you see something in their bid that I missed there that said that they didn't include installation?
I think it's just in there, and maybe it was just separate line item. I thought they had a different line item for their oversight, the beginning and the end of installation in their breakdown of cost. I'm trying to find it. Let's see.
Thank you.
See what page was their bid. Okay, so it would have been on their page 17. In the installation closeout, they had a pre-installation site walkthrough, installation supervision happening at beginning and end of installation. So that led me to think that this did not include the installation cost, and maybe that's why it was such a low bid in comparison.
Yeah, good catch. Good catch. Yeah, I felt it was just an incomplete bid overall. So I would propose that one be thrown out, as well as the high. And then that leaves the comparison of Weidner and Hackley. There is a lot more detail on the Weidner bid. But even so, putting all of that aside, our low still is Weidner. And I'm not sure if this is, I think that the decision point is based on that, but for more comfort with that decision also is the design cost is so much higher on the Hackley. And so therefore, even though the bottom line numbers are more similar than the other 2 that I'm proposing to throw out, so much of it is in design and not in the final product. And so for that reason, along with I have worked with Weidner in the past. They are a great outfit, and I have confidence in their ability to do this scope of work for us, and they are low bid. So I would like to request from the board approval to contract with Weidner as our signage vendor for a total, and I would propose that we stay within the 218,801 value, at knowing that we can make that work. Something I skipped over that I want to make sure that is before we get to the or cut to the chase, if you will. The items in yellow are items that I would confirm with them. Because the tax seems to be off. I'm not calculating the tax the same way. And I feel like we need to get a reimbursables number from them to be completely apples to apples. But the contrary to that, the grayed out items are items we don't need from them at a total of, at the bottom of that second sheet, $61,000. That could be kind of some give and take as we need to in order to make sure that the reimbursables are covered and make sure that items as noted in the notes column are covered, such as the history wall and the donor wall. And I think I have some directional signage in there, but where that 61,000 is reallocated and negotiated through the design process with Weidner.
So one thing that I noted when I was reviewing these bids was the two that we're proposing that be thrown out are the two that provided specific examples of what their signage looked like in a healthcare environment, and the other two did not. I don't know if either of the other board members noticed this or have any challenges around that, but that was one thing that I noticed. And I know that the GNU was the most expensive bid, but again, it also included installation costs that I believe are also included in Weidner and Shannon Hackley. They seem to have the most experience in the healthcare environment. So they also indicated in there they'd be willing to modify the bid based on our specific needs as well. So I don't know how set that high bid amount is. I don't know if you can speak to that.
Can you repeat that last sentence? What that is?
How firm the GNU bid actually is, because they had put in there that they were willing to talk to us about our specific requirements and whether we want, whether that bid really is as high as it is.
Yeah.
Yeah.
I mean, everyone's willing, it's a bid, they know that, yeah.
And then I guess the other question that I had was, in the timelines that I saw, it looked like we're looking at a max of 9 months to a year for the signage, and I'm curious about why we're bidding this so early, and if that's to pin down price or what the reasoning is behind that.
It's the design. Yeah, we need the input on the design side, so we need to get the signage vendor on board to be able to feed into the design drawings what's needed for electrical, where it's needed, anchorage, that we need that coordination to be occurring prior to completion of construction documents.
I appreciate all the detail that Donna is giving us,
Yes.
but I want to hear from our CEO what he wants to do.
I want signs.
Clearly
You know,
you
I
want
don't
signs.
have a point of reference, frankly. I have to rely heavily on Donna and the team to look at these because I don't have a reference point. I know what I want.
Well, I think it's a mistake for the board to decide. I think it's the CEO's job.
Well, and I think that our facilities and our compliance folks should be involved in this as well.
They've been in discussion as far as wall backing and what we've been in design where we're talking about the different signage internally and wayfinding and what's lit, what's not lit, we've been in that's been part of the design discussion, and this was based off of a lot of that. So gosh, I'm probably the least person that can comment on a sign. I like them to be readable.
Well, do you think the board is more qualified?
No, I don't. I think we're bringing it to the board because it's a bid, and the board is, you know, governing body. So
Well, I'm old school. I prefer to see the CEO say, this is what I'd like, and
you can't award the bid, it's over 25,000, so it's got to come.
I'm not saying you award it. I'm not saying you award it, but you make the recommendation to the board.
I have a really, really, really good construction program manager that has done this stuff in the past, and I have to rely upon her because she has way more experience up front in this stuff than I do, so.
So Donna, does Weidner have experience in the healthcare industry?
Absolutely, absolutely. Their major clients are Sutter and Mercy, and yeah, no, they're well qualified to work in the healthcare industry.
Because I don't think I saw that anywhere in their bid.
They have a map here that kind of, I guess of the dots on the map, maybe that's the wrong one. Yeah, right here gives you a sense of, I'm guessing these dots
So
represent.
if they have
Yeah,
Sutter, that's a
but,
big deal.
I thought Sutter was the GNU. Is that not?
You know, there's lots of Sutter.
Right. True. I'm still looking, I see an apartment complex. That's the only picture of an actual sign from this group, I think, that's in here.
She also chimed in.
Okay. Is she on?
She thinks that Weidner is the best choice. And once again, I rely upon.
Yeah, because I reviewed the project team in here as well on this group, and I don't think they put anything in here about any healthcare facilities. Maybe I'm splitting
I think
hairs.
that, I
Wouldn't
think,
signage for an apartment building be different from signage for a healthcare facility?
Which one are you looking at?
I don't know. On page 9 at the moment.
Oh, which one?
Oh, the very first one.
But Donna is saying they have a lot of healthcare experience.
They do. According to their map here.
According to which
Their
one?
list.
They have a little map in here that has little dots on it. And
The very first proposal does?
yeah, first proposal, that to me implies where they've worked, but not necessarily all
Doesn't
hospitals.
imply the type
Oh.
of industry, right?
I'm looking at their website, and on their front page, I'm seeing Sutter Roseville ED expansion, Hogue Newport Beach Pediatrics, Hogue Health Center Medical Office Building.
Yeah, I'm good with that.
That makes me feel better, Donna, because it's not in here.
Oh,
Yeah, agreed. I mean, again, my exposure to them is when I was at Sutter, so I know they do healthcare. It's just a matter of whether we feel comfortable based on their proposal. I hear you that it may not have come through in that.
Board members? Any questions?
No, I'm
Comments?
comfortable with Sean's recommendation.
Maybe you should just see his face.
Which of course would be Weidner, right?
All right, do I have a motion to approve the bid for Weidner?
So move.
I'm sorry, Donna?
Do we want to say the dollar amount of the 218? Like that's what I'm proposing. We contract with them for is the 218,000. And
Yes, and going back to the tax, we don't pay sales tax, right?
Yes, we
Steve?
do.
We do?
No property tax,
No
but sales
property
tax.
tax, we pay sales tax. Okay, thank you. All right, do I have a motion to approve the Weidner bid for do you want the low end or do you want the range, I guess is the question.
my request is the low end. We have a $200,000 budgeted. This is budgeted at 200,000, and I know that we can get it within the 218 and just use the 18 from contingency.
All right, then do I have a motion to
Yes.
approve awarding the Weidner bid for $218,801?
So move.
Thank you, Rich. Do I have a second?
I'll second.
Thank you, Ken. All in favor, Ken?
Aye.
Rich?
All right.
And I'll vote aye. Thank you, Donna, and thank you for bearing with my interrogation.
No, and yeah, let me know if it would be helpful for me to get some more information from them, but I'll use that as my guidepost, if you will.
Perfect, thank you. All right, next up is going to be our, number 14, Ad service for Sequel NEPA consultant.
Yes. So this was related to them needing additional dollars for the NEPA evaluation. This is final. So final billing. We have a current contract of $97,847. The remaining balance of that contract is $3,716. Their pending invoices add up to $29,467. Therefore, I'm requesting from the board the approval to do the ad service for $25,751 to make them whole for their NEPA services.
And this is specific to the NEPA review and information they need to provide for the USDA. So, do I have a motion to approve?
I'll move.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Rich?
Aye.
Ken?
Hey,
And I'll vote aye. Thank you. Thanks, Donna. Appreciate it. Okay, next up, Steve, we have our June 2023 financial report.
Yeah, true story. Okay,
We're excited.
as am I. So as Jerry said, we have June's financial report, which is the end of our fiscal year. And I've been presenting reports in draft. This one's in double draft. Because we typically will do some adjustments at the end of prior to handing the books off to the auditor. So we will have those typical adjustments, plus this is under draft as we continue our transition into the multi-view system. And then June is our first month with Cerner revenue in it. So a lot going on. So the financial statements themselves are a little rough from a results operation based upon the narrative here that we had a bottom line loss of $300,000. However, we had budgeted income of just under $1.2 million for a negative variance of $1.5 million. Like I said, in and of itself, that's quite an eye opener. However, there were two very large components, and this is where double draft comes in, or the typical adjustments we would have during the audit. There's two very large components of this negative variance that we had for the month of June. Included in our budget was $835,000 for our last round of provider relief funding. So we had until June, we received the money in 2022. We had until June 30, 2023 to spend, and then also to recapture any lost revenue that we had from our base year of 2019. We will report that to HRSA by September 30. And so everything I know leads me to believe that we'll fully recapture those funds into income. They're sitting in deferred revenue right now on the liability side of the balance sheet.
and we don't know what the dollar amount is yet.
The dollar amount that we received was $835,000 in total. What I believe, I'm pretty certain, is that we'll be able to, we won't have to give any of that back.
Okay.
So we'll bring it all into income.
Okay.
So it's really, again, an accounting entry because we had already received the funds. The other big piece is one of our supplemental payment programs, the calendar year 2022 quality assessment fee program. And this is an IGT program where we put up a intergovernmental transfer and then we get the funds back. This disbursement for calendar year 22 was scheduled to be made within our fiscal year, June 30. It's been pushed out into the fall of this year, 2023. We already have the numbers. We signed the commitment letter. I signed the commitment letter today. They have the exact numbers, the in and out. And so we will receive these supplemental payments by the end of calendar year. And this will just be a discussion with our auditor. I've talked with my peers, and in situations like this where we know what the amount is and we know that it's funded and it's going to happen, and it falls within our fiscal year, they'll allow us to do an accounting entry to recognize it as income. So when you put those two together, that essentially makes up our variance for the month of June. However, we did have negative variance in patient revenue for the month of June. I'd like to blame it on Cerner, but I think those were, we did the real numbers. One of the really interesting thing about Cerner is that when the day's over, when the clock strikes midnight with Cerner, that day's in the books. So that's why it's so critical that everyone gets their charges in the same day. So the doctors complete their charts, they do their order, they document, and the charge is captured. Otherwise, we're capturing charges somewhere down the line. And it's even more significant when we get to a month end, or in this case, a year end. But what was very interesting is what Cerner has the capability of doing very easily is they have two fields. One is the service date and one is the activity date. Service date is when the actual care was rendered. Activity date is when the charge went into the system. And so we can just run a report from July 1 forward and say, show me everything with an activity date of, prior to July 1. And the number was quite small. As of the middle of July, I haven't updated it yet, it was just $19,000, which is pretty impressive. So it was nice that we had almost a full month to go through with Cerner in the first month. So we had a good chance to capture those charges and make the edits. So it wasn't a significant amount. So short story long, we were negative to budget for the month of June, but it was all primarily within the acute, the inpatient swing bed service area, both the room charges and the ancillary charges. Outpatient was pretty close to budget, just had a negative variance of 33,000. And it's the same relationship as we, if you look out to DK or whoever, can you pop to the second page? Can you go to page 2 just real quick, 2 of 7? Woo! Look at your paper documents. Blow that up a little bit. Okay, so again, this is the detailed financial statement where the logical categories of revenue and expense are presented. The first 3 columns in are the month of June. The 3 columns off to the, there we go, perfect. So those 3 columns off to the right are year to date, which is our full fiscal year. So for inpatient revenue, which if you have your document there, it totals at that line 6 over to the left. We were negative to budget $1.1 million. And the bulk of that came from swing bed services. There's 2 components, the bed charge and then any of the ancillary, the diagnostic services or the supplies and pharmaceutical and those types of items. It was all kind of off the swing bed program. And that's something you can control a little bit. It's just one of those things where we look to seek for proper patients that we can care for. And sometimes you get it, sometimes you don't. But the good news was our outpatient revenue was positive to budget, almost $900,000. So when we talk about this new facility and we talk about whether or not there's a need for it, I think that number demonstrates the need, that we're positive to budget and there's a demand out there for healthcare in this space. And so get those providers in here, then there's a great opportunity to significantly enhance our financials. Our adjustments to revenue kind of ran right around budget the whole year, both month and year to date. Expenses, we've talked about a little bit. For the month of June, we had a negative variance in salaries and wages, which is our employees, our W-2 employees. And then we also had a negative variance on contract labor. I went into a little discussion in the page 1 narrative that June was our Cerner go live. We built up staff so that, as we discussed with the 2 physicians from Oracle, that when we turned the machine on, we were ready for care. And we did provide that care. So now we're going to do a slow ramp down of backing off that staffing level and continuing to work on bringing in permanent staff. There was an element of contract registry staff in that Cerner buildup. And additionally, we've had some extended leaves of absence in mandatory staffing areas that we've had to use registry staffing as well. And I talked about that in the narrative. And that's the other thing that we'll attempt to bring down going into the new fiscal year.
The increase in outpatient revenue, primarily where? Is it urgent care? Is it clinic visits? What?
Well, we had a lot of emergency room utilization, Rich, yes. That,
Do we break out urgent care from emergency?
That's covered. No, just so you did look at it.
I'm just curious whether urgent care is a growing phenomenon, because I see it elsewhere.
The walk-in has been,
More walk-in.
they've been busy. That's, and I think that's primarily because the lack of primary care physicians getting more established. So because it's not a scheduled appointment, that's where they go for non-emergent, but I need an appointment. So I think it's been fairly stable and growing to a certain degree.
Well, I think as an industry, urgent care has been growing in the last number of years.
Oh, yeah.
Well, part of that might be it's been hard, not only here, but everywhere to find
Everywhere.
providers.
But also, I think travelers, if they have an illness, feel comfortable now looking for an urgent care center as opposed to running to the emergency room. So I was just curious whether, but you're saying we're not seeing any growth in that.
Our volumes have been steady and growing a little bit. I think though it's due mostly to a lot of the walk-in will get local people that can't establish because we don't have an established physician for them. Either 2 aren't accepting any more patients or we have a locum in there. So they're using the walk-in kind of as a family medicine, spot versus urgent care. Now we do see, don't get me wrong, we do see, especially during the summer, folks that use the urgent care or the walk-in that aren't meeting the criteria of real emergent medicine. So we see some PCT hikers and things like that, but mostly it's being used as a family medicine, almost a primary care.
Are you suggesting that we need to market it as an urgent care in addition to a walk-in clinic?
Well, I think we ought to think about that, particularly as we're looking at our new facility.
Yeah.
If urgent care is a growing component of the healthcare,
Yeah.
then
Might be
we ought to
something
be in
someone
the
would
game. Yeah.
recognize, they recognize that versus a
Right,
walk-in
yeah.
clinic.
And it does impact the emergency care. There's no question about that. But
Yeah, what's really effective in urgent care is when it's not attached to a hospital and it's someplace that is
That's
more
right.
populated. And I'll give you an example. When I first came here, I said I would really like to take a look at, as one of the projects, is to take a look at maybe a seasonal urgent care on the peninsula.
Absolutely.
Because then it's right there and you market the heck out of it. You just market the daylights out of the thing. Because then it's there and that's where they seek care. If it's an emergency, they're calling 911, right? Or they're getting an ambulance and they know where the hospital is. They're not going to establish family medicine care while they're here. They have a doctor at home. But I think that the urgent care in a heavily populated area and heavily visited area in the summertime, something we definitely need to take a look at.
Shut it down in
Yeah,
the,
shut it down around November. but it's a seasonal thing. It opens, October, November. We'd have to massage that a little bit, but I think that's something that I would really like to look at.
Yeah, I think that's a good idea. However, it's not that long of a drive to come from the country club into Chester.
But, it's
Well, some
interesting,
people never
they never leave.
do,
I
or they'll
think
go
the
the other
temptation
direction.
is to go to the emergency department.
Or they'll go to
That's
Susan, or they'll go to
correct.
Susanville.
But this is the alternative to going
Yeah.
to emergency.
I actually, part of the thing, I actually go out there a few times just looking for property that would be useful, for a temporary or urgent care, seasonal urgent care. I looked at O'Neill and different things that are near the gates and
Well,
stuff.
I saw PDH, it looks
Yeah, they
like
did
it
it
has a mobile.
Yeah,
urgent care,
I'm gonna talk to them about that. It's mobile clinic.
Mobile clinic.
Yeah, I don't know what they do. I don't know what their scope is.
Yeah, I just noticed.
I've
that
actually seen urgent
in the
cares
Fox
in
News.
mobile homes. Big mobile homes. I've seen urgent cares where they have 2-bed urgent care with stitches, and they can get stitches, they have basic medicine, they can do splints and all those kinds of things. I've seen that.
So my
elsewhere.
question would be then, is that something that we could contract with someone to provide rather than running ourselves, a mobile urgent care, or mobile,
Oh, okay, yeah.
would that
I
be?
mean, there's
something
lots of
we
different
wanna
ways to slice it, I think, but
I wasn't going there. I was thinking about
establishing
taking what we have existing and kind of
do? Remarketing it.
remarketing it, or,
marketing the walk-in as an urgent care.
yeah.
John, what happens if, I'm thinking this through correctly, if we have urgent care out there, but at the same time, we're fortunate enough to get a cadre of providers, local people living here. Is that going to undermine the services provided to our
We might rotate them
in-house
over there,
providers?
right?
No, I don't think so. I think that the urgent care would literally be something that our visitors would make use of, because it's cuts, sprains, it's things that you get when you're up here
Got
running
a fish
around.
hook in my ear.
Yeah. I don't think it would undermine the primary care family practice, which is going to be more.
That's my
No, I don't believe that they would I don't think they would collide. I don't think they would.
The ones that I'm familiar with, the family practice physicians take a turn at the urgent care center.
Yep,
Yeah.
and
So,
even more so, that a nurse practitioner or a PA does really well in an urgent care
Yeah.
setting where it's just minor stuff.
that's right.
And they make the decision, this needs to go to the emergency room. And then they direct them. You need to go to the emergency room. This is too complex.
Well, there was also, where I came from, our walk-in clinics. We had an extension of our walk-in clinics that we called client services, where we were doing all the pre-employment screens, and DOT physicals, et cetera. And I wonder up here with all of the industry we do have up here, the truck drivers, everything else, is there an opportunity to expand some of our walk-in business with DOT trained providers, which can be an NP or a PA?
Yeah.
Interesting.
So.
Great example was the
That
Forest
is
Service
a
this
really
year,
good
Correct.
example.
where we took the Forest Service contract and they brought all their young, as they're ramping up for the summer, we did their physicals.
Mhm.
Yeah, no, I think that's a great idea.
Yeah. Like that.
Because I think previously it was just onesie twosie individual provider offices, but having a central place for it
Right.
makes a lot of sense.
And on top of that, if you want to think about
Yes.
how that works, I would, I think it'd be important to spin up a direct to employer piece where you lock in a good rate for people who need physicals on a regular basis, rather than going through their insurance. You do a cash lock-in direct to employer period where you're doing these things for a cash number. It's a little bit discounted because we don't have to go through the rigmarole of their insurance. And I would love to see things like that where we establish it for people who need that yearly physical, direct to employer. And that's seasonally a tremendous boom can be for us.
It's refreshing to hear a couple of strategies that we can consider. as we
Yeah, if
move
we can get out of the
forward.
way of Cerner and
Well, you took care of Cerner today.
we took care of Cerner. Anyway, so lots of thoughts there, certain things that I think would bring attention to Seneca and would meet the seasonal needs and the long-term needs. There's lots and lots of really clever ways to go about doing this.
Now, does the definition of an urgent care by law differ from a walk-in clinic? Like, do you have to have anything
I've had this
different?
conversation with Steve for the last 3 years. I
Okay.
think so, to a certain degree, right, Steve? Walk-in means no appointment, urgent care means urgent care, no appointment.
I had to Google it. Urgent care means a business that's prepared to treat a higher level of, they actually say that the patient is in some jeopardy. That as opposed to
Walk-in, which is more family medicine.
Well, you can go in and get your COVID test at an urgent care.
yeah, you know what it is. It's, to me, it's a billing, it's a revenue code, you know, when you're urgent care and it's extended hours. But the true definition is that urgent care, if you put yourself out of that, you better be able to treat some higher level of care in that setting. Because the patient, there's, I guess, an implied,
Anything can walk in.
yeah, there's
Then
an
again, anything walks in.
Then you
an
need
implied
some
ability
triage.
to treat some level. They don't need to go to the ER, but they're in some form of jeopardy, if you will. So,
You mentioned an after-hours component to that
There
too.
usually is, it's not Monday through Friday, it's usually urgent care is open until like 10 at night, you know.
Saturday sometimes.
I've seen some that are
Better Monday through
8
Friday,
to
8 to
5,
5,
yeah. In a storefront, in a shop.
Yeah, it's owned by a physician and they don't want to overcome price.
But it sounds like it would change the flow possibly of, because you'd have to have someone to determine if they
Well-
needed immediate care, right? Versus waiting their turn until they're called back. That might change your process and flow.
The number of licenses.
Yeah.
So keep your eye open over at the Peninsula Village for a vacancy out there maybe.
I actually would, you know, I looked at the old Wakanuba, or where Wakanuba is, I looked at all that little area across from
There's not much
or
available.
El Lago. For something that we could pop in urgent care, I looked at McNally or McNeil's,
Storage here.
their office there. You know, so I poked around, then it came up.
I'm just
Can't
saying,
do this right now.
keep your eyes open for something and, maybe grab something while we can.
You know, always looking. Yep. Thanks, Steve.
Thank you.
Go ahead.
just want to go over AR real quick. We don't have a report from HRG. They're not going to provide us a report.
At all?
Not much of one compared to what we previously got. So I'll get what I can from them, but they're basically just going to give us numbers. They're not going to go into the detailed analysis that they did previously.
Fine.
Which is
I think
fine.
that's what we were expecting.
Just collect the darn stuff. And, you know, okay.
What about with R1?
Yeah, I talked to them today. They're going to get back to me about what they would like to put forth, and then we'll have a discussion about what we think is meaningful. For the first 2 months, you know, in June, we collected about $10,000 off of our Cerner revenue. So it basically wasn't much to talk about. It's really at such a deep level about what's happening with the claims on the editing part. So July, we probably will have some kind of report. It's just, again, July's also been, a lot of our claims are getting held up because like I mentioned to the physicians there, is we're still tweaking the system, you know, 2 months in.
I like their thought about getting it around so it's automated.
Yeah,
Send it in, it gets back approved.
That's what
That'd be nice if we get
That's
there.
what we're shooting for,
So
so.
you
Yeah.
gotta talk to the insurance companies.
Yeah.
Now, one last thing is, again, a continued issue is the long-term care billing. And we had a call this week with HRG because they're the ones that did all the billing and are handling it. And basically what the payer, California Health and Wellness, is saying is they have 45, we thought calendar days, it had to be calendar. They're saying 45 business days to respond to us. And as of today, as of this week, that we had 20 more business days. So we talked to our contracting consultant person, and he gave us a contact with California Health and Wellness, and it was essentially the person who did the amendment to do long-term care. So we're gonna send it all off to her and see what kind of response we get with that. And just, if we get kind of a him and a ha, I'm also gonna dig up our actual contract, because there's provisions in there as far as, you know, how long they have to
respond and resolve.
for a clean claim, because they're telling us now that there's nothing wrong with our claim. They just don't know why it's not paying. So anyway, that's the escalation we've done to this point, and we'll see what response that gets.
Now, do we know if EPHC is having similar challenges?
Everybody
Everybody,
who's getting paid.
okay. Well, fun times.
Actually, they're not billing either, so.
That helps.
So, yeah, no,
Because if there's certain things, so.
yeah, everyone's having this problem. We were talking a while back about escalating things with, at that time, payment issues, mainly with Anthem, was where people were having most of their issue. And at that time, it wasn't a big issue. Now it's obviously changed. So if we get a bad response from this avenue through the contracting people, then I think we'll look at what our options are at that point. So we ask for the hospital association to help us, or what we do, so.
Sorry about
All right.
that.
Well, thank you.
Yeah, that's that. Hopefully, good news soon, because that number's getting big.
Yeah,
I'm guessing we can't accept this report, so I guess we can accept
we
it in
can
draft
accept a
form.
draft.
A draft.
Have a
Okay.
motion to accept the draft.
I'll make a
Angela
motion to
Thornton.
accept the draft.
Thank
Second.
you. Thank you. All in favor, Ken?
Aye.
Rich?
Aye.
And I'll vote aye. Thank you, Steve. All right, so that brings us then to number 17 for our strategic planning critical access hospital report update from Donna.
I'm back.
Thank you, Donna. Thanks for sticking with us.
Okay, so going through the report, CEQA has been officially completed in that LAFCO, the final step for annexation of the property into Chester Public Utility District, was approved on July 17th at the LAFCO meeting, therefore completing the swim lane entirely.
Yay.
So that will fall off the report for next time. NEPA, we, at the time of doing this report, we were in the middle of, we were completing the public comment period. Public comment period has been completed, and there have been no comments that have been reported to us. The comments were going directly to USDA, and they haven't indicated that we've gotten any, and we're proceeding down the path to getting approval. However, they have indicated that in order to approve NEPA, they also have to approve the PAR, the preliminary architectural report. So that was late breaking news on Tuesday. And so we have since provided all the information that they have asked for, with two caveats. One being they were asking for the contact and resumes of our special inspector, and I have provided that information for our grading special inspection company. But we do not have a special inspector yet for our building, nor should we, because we don't even have complete drawings or approved testing, inspection, observation forms. So that information has been provided to them, and we're awaiting any feedback from them as to whether that is going to cause any problems. And then secondly, they have asked for the contract for the grading scope, which we do not have at this point. So that has also been conveyed to them, and we would be we're also waiting for confirmation that that is not going to hold up NEPA approval. So I think likely everyone knows that we were aiming to start the tree removal following the groundbreaking ceremony that occurred yesterday. And we are in a holding pattern until we can get this NEPA approval, so that we can continue with the tree removal following that.
Is that why we didn't cut down a tree yesterday?
Yes, sir.
Yes. That's why there was a clear line between the pavement and the property over here versus our dirt pile that came from another part of our property over here.
We didn't even disturb the dirt. We didn't take dirt
No.
from that property. We did not disturb anything because this is not complete.
Yep.
Don't want to jeopardize anything. So,
Yes. So we have as Steve referenced earlier, we do have a meeting on Monday with USDA, and hoping to get, if not tomorrow, at least clarity Monday from them as to getting the NEPA finalized. Moving on, the helicopter landing site, flight care pilot, in addition to having done that yesterday at the groundbreaking ceremony, also did a flyover with Sean and Judy. And we are now working with Bolton HGA to incorporate what we can in order to have the emergency services helicopter landing site inclusive of inset lights, likely amber colored, fencing, a lighted windsock, and a beacon on the rooftop. That's what we're working to incorporate into the drawings, and we will not be pursuing approval through FAA, and the approval through the DOA is only a recommendation from a public service agency, correct, Sean?
correct. Yep, so I had a very good meeting with the Department of Aeronautics, and they basically outlined everything that we cannot do, which we qualified as a heliport, which has to be certified. So we're going down the right path.
Good.
And that was great that they were able to do that flyover yesterday.
Yeah.
I think that was really a really neat thing for the community.
Definitely.
They're excited at the idea that they don't have to go to the Chestnut Airport.
Good. I wonder if that's why they made the third pass.
It was the first flyover for some of the crews.
It was very cool.
Agreed. Okay, moving on to harvest plan, kind of referenced within the NEPA, but we do have full CAL FIRE approval of both the timber conversion plan and the timber harvest plan. Set to have Sierra Timber Services do the on-site post-approval supervision. There's one thing that we're finalizing with that, and that now that the licensed timber operator is selected, they need to be named on the CAL FIRE permit, and so we're just getting those signatures from our licensed timber operator to get filed with CAL FIRE. And Pete from Sierra Timber Services is working on once we get the signature from the LTO, he will get that filed with CAL FIRE.
So I noticed yesterday several of the trees are marked, so.
Yeah, we've marked them all. There's going to be some additional marking that goes out there so that it's very simple for the timber operator to know what's taken, what we call leave trees, things that they leave alone. So on the 25th, we probably cover this, but we had a walk, site walk. We also had the biologist did a briefing about what to look for and stuff. So we've done the education part of it. We're just waiting for NEPA, and then we're off to the races.
Yep. And in regard to the reference dust control plan, I did get word back from Northern Sierra Air Quality Management District that they are not going to be monitoring the timber removal only once we start the grading. So I do have that email from them, so that is a cleared mitigation measure for the purposes of the timber harvest, and then we'll get they're reviewing it for the purposes of the grading, which I'll stay on top of for that purpose. Moving on, no news on the Wildwood easement. That's remained unchanged. Financing, USDA financing, again, continue to work with USDA to get all the questions answered, PAR finalized. Our deadlines around this are getting everything to them by August 4th so that it can go to the national office by August 14th for a September 30th funding deadline, end of fiscal year, September 30th. So everyone's working very diligently on that. The other funding, we did get declined for the federal earmarks, but we will keep this on the radar for next year. We have no update on Senate Bill 395 or if philanthropy is continuing. Sean and Chelsea are working diligently to get the word out there on that and pursue any philanthropic giving associated with the project. Schedule, still really no change on this since last time. We're fully dependent on maximizing the timber removal and grading and site work this year, and working again diligently to get that moving forward. Budget, we're still validated at the 55 point, we're still working on the validation of the 55.5 million for the design build entity for a total of the 72 million. Tracking on that. With design, we have gotten word, not work, from Plumas County that the grading package is approved. So we're just finalizing how we need that approval formalized from them. We are we're trying to figure out where CPUD input on fire needs to fall within the approval process. Normally it would be something that they provide feedback to the county on, saying we approve, but they don't have that function within their organization. So they're consulting that out, and we're trying to get that information to the county. It does not currently appear to be holding anything up, surprisingly. So it doesn't seem like the county is asking for it, but we know that it needs to be addressed.
Donna, an update to that, I did speak with Adam and Chief Belzerini, and they will be meeting with their consultant next week.
Great. We are in construction documents, have been doing meetings around low voltage and the site utilities such as generator location and setup, and as well as propane, all the site tanks that are needed. All that's been ongoing to date. We've been going over details around the mall configurations, the donor wall, the history wall, talking about all that. So getting into the nitty-gritty, working on getting out the furniture vendor RFP so that we can get, again, similar to the signage that we talked about earlier, get their feedback to make sure all that's incorporated into the design as we're in construction documents, make sure we're not missing any of that needed coordination. And we're still set for submitting the building design interiors in November or December. Medical equipment planning, we are our top button on this is really getting our vendors selected for the architecturally significant equipment items. So they're working they've been working to get some vendor days, but I feel like we've lit a fire under them to make sure that they know how important this is to the architectural design. And we're looking to get the vendors identified for the radiology equipment, the sterilization, the booms and lights, those big structural items that are structurally and utility impactful. complete so that it's all with the designers by September. So that's
And
what we're.
I left you a voicemail. I need to get you the contact information. I met a woman who apparently her company provides medical equipment, primarily lab equipment, to Stanford. And we had conversation around this, and she indicated that she could potentially get us equipment like the hoods and things like that for a significant discount over a retail price.
Okay.
And possibly do the install. So I'm not sure exactly how that fits into all this, but I figured I would pass her contact information on to you, which I told her I would do, so that way we could see if maybe that might work into our process here with the medical equipment planning.
That would be great. Yeah, I think that's a good way to handle it. If we can put her in contact with Introba is I think the path to handle that, so that Introba has the are still managing the selection there, so that we're able to incorporate the cost savings, but not getting outside of the construct of their contract.
That sounds perfect.
Okay, great. Thank you. Construction, as we all know, with the groundbreaking ceremony was yesterday. We've talked about the Bolt contract GMP timing and the site construction contract. I feel like we've talked about this, but I'm sorry. I'm like, Bolt has, let me know if I'll just go over the details. Bolt has bid to over 50 site subcontractors. We are not finding subs that are available that also meet the skilled and trained design build workforce requirements. So we're looking at the possibility of having that contracted direct to Seneca Healthcare District, and SHG Legal and Bolt's Legal are working together for the details associated with this potential modification. Late breaking news just today is it's a possibility that we won't have to go down this path. Bolt has let me know that they have found one subcontractor that is wanting to get them a bid that does meet the skilled and trained workforce. So if that works out, that's definitely the path of least resistance. And we would want to entertain that.
Great news. Thank you, Donna.
Yeah. Fingers crossed.
Yes.
Right. Any questions for Donna? Thank you very much for going through all this. We really appreciate all of your work on this, Donna.
Thank you, everyone.
Thank you.
Thank you.
All right, moving on, number 18, EMS update. Sean, you want to lead this one?
Sure. So just a caveat to this entire conversation. This is a very dynamic, there's a lot of dynamics associated with EMS in the basin. In no certain terms, I've been if you've not gone to the CPUD meetings, Adam Cox has basically proclaimed that their budget is going to be able to suffice through the EMS and fire through, I think, the end of November. So without an income stream that is going to support fire and the EMS at a Chester Fire, they don't see a long pier after November or December if they can't get income streams. And the income streams that he is referencing is twofold. So he calls it the Hail Mary. That is the ballot measure that's going to be on the November ballot coming up to support the fire service. I think it was 400 and what per year per parcel.
Yeah, 400.
I haven't seen they're trying to pass a parcel to support the fire service for longevity fire and EMS service, but that's not going to be enough. Just that is not going to be enough. They made it very clear that they need an infusion somehow through Seneca Healthcare, whether that is a memo of understanding where we use their paramedics and we pay for their time
and run billing through.
And bill through us. But the board knows that we cannot do any billing and get cost-based reimbursement if there's another one within 35 miles. So it's not just enough to do an MOU with Chester Fire. We would have to do an MOU with Penn Fire as well. Otherwise, it's a no-go. so they have the MOU. I think the MOU after my conversation, I had a conversation today with REMSA, CareFlight. They're doing a very similar thing up in Mayors Hospital in Fall River Mills. And incidentally, their run volume is very, very similar to our run volume for the entire basin.
Interesting.
And without cost-based reimbursement, and just fee-for-service reimbursement, is made very clear that their ROI shows about a $290,000 to $400,000 loss with the same run volume. That's not using the cost-based reimbursement.
Right.
We haven't applied that yet to that scenario. Their guess is that it breaks even on one rig, not two.
But we have Whipley doing.
Correct. So we're engaging Whipley for $10,000. They are going to do a feasibility study for both of them. I've notified both fire services that what Whipley is going to be looking for. And the initial reaction was, oh my gosh, this is a lot of work. We don't have that information. This is going to be really hard to get. So I had a conversation with Steve today. So we have a $10,000. Our feasibility study is $10,000. But if we can't get information and we can't get the appropriate information, and there's a change order to that $10,000 to try to get this, I don't think we need to bear that cost. I think that if there's a problem with getting information from the fire services, that any change to a $10,000, which we want to sit at, should be paid for by them, because they're getting data to us. This is us investing $10,000 in feasibility study just to see if it pencils. And if I can't get data, I'm not going to spend another $5,000, $12,000, whatever dollars for Whipley to go chasing information. And I don't want to be a jerk about it, but listen, we're really trying to help here, so we need cooperation. I don't want to spend anything more than that. So Whipley's going to push forward on that. We're going to launch that right away, but the caveat is going to be 10,000 is our cap. We don't pay for anything more. If there's a change order to this because we can't get the information from y'all. So that's going to be
And the
put out
draft
there.
MOU you're referencing is really a partnership between all three agencies.
Yeah, so there's different ways to slice and dice this. And I'm not going to comment about the different models, the way this can be modeled, because right now, without that feasibility study, it's not even worth trying to model it. It's just not even worth going in that direction yet until we understand the financials of this thing, whether or not it's even viable. I can tell you this, it's not viable without both. That's for sure. We will not be engaging in this conversation if we can't get both to come along, okay? And then there's the cost structure by how we create these MOUs, and there's different ways to do that. I learned a new one today, which is great, but we're not going to model this thing until we at least understand with the run volume laid against a cost-based reimbursement and our payer mix. Without that, the conversation stops, because I don't see, got to see the numbers, sorry.
All this to be done before November?
So I've done the MOU. I have a draft MOU, and it's actually in the hands of Chester Fire right now. We'll see what they respond. I have not put it in the hands of Penn Fire yet.
I was waiting to see what Chester Fire says first before, yeah. That makes sense.
So there's a ballot measure floating out there?
I guess it's going to be on the November ballot, and once again, for Chester Fire, survivability requires not only that, but a relationship with us. And a relationship with us means we have to have a relationship with Penn Fire as well.
That's
There's a
because
lot
we
of
can-
moving
I'm just
parts.
not optimistic about their chances of getting that passed.
Well, I'm not going to
All we
guess
can do is hope
I'm not going
and-
to guess whether it can pass or not. I can tell you that just living here, a $400 per parcel per year is a lot.
Yeah.
That's a lot.
Well,
But I
it
did
follows on the heel of
what we
do. Well,
I don't know. Good luck. I mean, I hope they,
Yeah.
I really want to see them survive, but, I'll make the statement to my board and to anybody listening that Seneca cannot be the cash cow that saves this,
Yeah.
because we have fiscal responsibility, and we're building a new hospital, and that's, you've heard today, there is a lot of outlay, financial outlay from our reserves that are going into this. So we're not in a position right now to start throwing money at something that may or may not be salvageable, and I'm fiscally very aware of that. So, but
we're doing what
I
we
want to be
can.
right for the community, so that's why that's why we've been having a conversation.
Yeah, we're doing what we can to support them and to plan and to see if it's feasible for us to provide the billing, because we can take in more reimbursement than what they are able to
Yes,
bring in,
we
which is
can.
why they've indicated to us that they want to initiate this.
Correct. So we are doing our due diligence.
Yeah.
That's an organization.
Any other questions, comments?
Good to know.
All right, thank you, Sean, appreciate it.
You bet. We'll keep going.
Okay.
This will be a standing agenda, item, by the way.
Yes. All right, then we move into your report.
Oh, my
Your
report.
further
Well, I'm
report.
not going to go over the first part because Donna just absolutely stole my thunder. I will mention that, I'm going to reiterate that we had a really great ceremony yesterday. I thought it was timed properly. It was great. I really do wish that the NEPA thing was taken care of so we could have fallen our first tree.
Good to know you glued your eyes closed.
Yeah, the little funny stories about Sean and Dr. Levin, yeah. Dr. Levin. Let's go to legislative updates. I learned yesterday, because we had a representative here, we had a staffer here, that AB 69 looks like it's going to go down in smoke. It went to this, AB 69 was the extension of the Senate Bill 1935 to push out the seismic requirements to 2035. There was also parts of the bill that were talking about funding sources for critical access hospitals, especially those that are considered, there's a word they use for it.
Financially distressed.
What's that?
Distressed.
Distressed meaning near closing. They're closing, right? Not, we might close, or we're going to have to close in 2035, in 2030, but near closing. My understanding is that when it went to committee in the Senate, there was so much markup on it that its chance of living is just gone. So I doubt seriously if there's going to be a seismic change. 2030 will probably continue to be the date, which makes me very happy that we are where we are
Yes.
Yeah.
right now, that we've
Indeed.
jumped on this and not waited for legislation. It does affect some of our sister hospitals, but we'll see where this pans out. 525, unfortunately, is getting a lot of momentum.
And there's nothing we can do about it.
Nothing.
Refresh me on 525.
525 is the healthcare minimum wage. It also, what it does to us is all healthcare workers, regardless of where they work, get a minimum wage of $25 an hour in the whole state. Regardless, that's doctor's offices, that's everybody. But what it does, because the compression, it pushes everybody up, including the exempt employee language in this bill. So roughly, and we haven't done the exact numbers, but I heard yesterday a number from another facility talking about a $3.5 million operational cost with compression and everything else. I told the staffer yesterday that that's not sustainable at all. There will be hospitals closing all over the state of California if they impose this. But unfortunately, in the environment that we live, from a political perspective and who the supermajority in Sacramento, this looks like it's gaining a lot of ground.
And no funding backstop.
No funding
to-
backup. No,
Yeah.
it's just it's a complete 100% overhead. Now it'll be phased, but it's irrelevant. It's just phasing the death of the hospitals. If this comes through, I can tell you that Seneca will be severely impacted by this. So everybody will be severely impacted. But you heard from the financials, that we can't take a $3 million.
Or CHA and other
Their
organizations.
CHA is walking the fine line on this one because
Yeah.
they're big clients. They're already there, right? They're there. What do they care? It's not an impact to them. This is really going to impact
All the smaller
community
facilities.
hospitals, rural healthcare. So they worked for an exemption, and no exemptions were going to be granted by this. They're still trying to work with the unions, but
Well, it applies to all medical clinics regardless of,
physicians' offices.
yeah, anything. Mhm.
So this is a huge, impactful bill that I'm sure if it gets passed will be challenged from a legal perspective, but that doesn't stop it. That doesn't create a reprieve. They may put an order out there to try to stop it. I'm really nervous about 525, I'll be honest with you. So there's that. Yay. Seneca campus upgrades. With the exception of the continued effort in the LTC, we have stopped or we're severely scrutinizing any current upgrades to the existing campus as we focus our attention on the new build. There is one that I may bring to the board later would be the build out of the boneyard to move business services upstairs and create more clinic space down here. That's going to be dependent upon our ability to develop program, get providers and things like that. So that one's going to kind of sit there and shuffle a little bit until we can see a little bit more clearly in the future with what's going to happen with our providers.
We did the design for that.
So we have a basic design. It would have to go into a build out of that as built. But yeah, we've done the design. We kind of know what it's going to look like. All right. Physician mid-level recruitment. And this is less of an update. So Bill McGinnis canceled, did not give a reason. So he will not be coming. Right now, we've got nobody else coming up here. Dr. Wing is not scheduled yet. Dr. Russo is returning August 7th. We are going to literally, he's on a 5-month locum again. We're going to really work with him. He does show an interest in full-time. I threw a great number out. He threw a greater number out. So we're going to meet somewhere in the middle and see if we can't get him to come here full-time. There is going to be one of my major focuses and the focuses of this organization, now that Cerner's kind of tail ending and that we're going to be kind of more or less turning over the build to the construction to our GC, but we can not take our eyes off the ball, but less activity in that regard, is we are going to have to get super creative in recruitment. There's just no other way around it. It is the key to the health of Seneca and this community that we get providers that are here full-time, fixed into this community, and establish that for our, not only our numbers, but just for people repatriating back here. A locum's great, but a locum's going to leave, and people know that, right? They know it's temporary. So suffice to say that so much of my energy is going to go into recruitment and permanent recruitment. It just has to. And we're going to, unfortunately, be spending some money doing this. But we're 3 years now. I'm almost on 3 years. And we haven't had a successful recruitment. It's not lack of money. It's not lack of quality of life. Everyone that comes up here looks at the way they have to practice and go, oh my gosh, this is panacea. It really, they're not pointing to anything that's an ick. It's a matter of they have so many offers. And then it's a matter of recruiting both of them, not only the physician, but their family, their significant other. So we're going to have to get really creative.
Figure out how we compete. Yeah.
I think there's some other barriers out there. I mean, I've talked to so many young people. My children who are of childbearing age come to Chester, live here now. Yeah, worried about the schools, worried about.
Well, there's housing, there's schools, there's what happened at the Dixie. You know, there's a lot of factors that we cannot control.
No, I know.
That are going against us on top of what is just a huge shortage in providers. It's astronomical. You know, it's just nothing we've ever seen before.
I just wish there was something within our control in that mix. But
yeah. Well, and then with Dr. Wall's retirement coming up, we have to seriously consider another locum. They're expensive, but it's a provider until we can get that 1 or 2 or 3 that just want to hang on and live here in this wonderful community and provide care to this community. So recruitment, Seneca campus upgrades, long-term renovation, very close to completed. And then
That last 1%, it's always the hardest, right?
Well, we got the word today in our executive meeting that we're going to go ahead and fill our spots. We're bringing our census back up.
Great.
So we're going to pull the trigger and start accepting people into our long-term care, new residents. So where that's going up because it's been sitting low too long. Okay, that's my report. Any questions?
None from me, anyone else?
Thank you.
Thank you, Sean.
Yeah.
All right, Judy, you're up. CNO report.
Okay, I think I promised you last month that I was gonna talk about COVID anymore, and that was a complete lie.
Yeah.
We see this.
We're gonna talk about COVID forever, because it's definitely rearing its ugly head back up in our community again. And as I've talked to some people who have been recently, diagnosed with COVID, The majority of the time, they can describe that either they had a whole house full of visitors coming from all over, and then they contracted COVID, or they were at some super event and they contracted COVID. But it's here, and we have had one of our patients was COVID positive, so we have seen an admission related to COVID. So it's still here. So what we're trying to do is just retain that hypervigilance of, you have a cough, you have a fever, you've got a runny nose. Let's not just automatically assume it's from the green pollen. Let's make sure that we always rule out COVID first and foremost, and then we'll move through our differential diagnoses of upper respiratory issues. But we just have to remember that it's still around. And,
It's around nationally. Wall Street Journal had an article today.
That's spiking.
Yes.
So quick question, what's your confidence level in home tests?
very good,
That's
Very
good.
good.
very good.
Very high confidence.
Yeah.
They're excellent.
Uh-huh. So,
I've had a few family members, not living here in Chester, but took home tests and they came up negative, but I was still like.
well,
sure.
I'm glad they're still testing, because there are a lot of other things that are circulating that can cause the same symptoms, but we want to just really focus
Yeah.
and, get COVID out of the running first before we move
Yeah.
to other.
And just, this is just recommendation that they don't just test once. Sometimes they may be getting symptomatic and they test and it's negative, but there's not enough antibodies in there. So have them test again, because, no, right, it has to trigger it.
So I'll keep talking about it.
Please no.
So summer is back, as evidenced by the bat exposures we're
There's
seeing.
been a
in
lot of bats
emergency
around. I've seen a ton of them.
There are a
On the
lot of
West
bats.
Shore, oh my gosh.
There are
it's
lots of mosquitoes though,
crazy.
so I'm like, keep going.
Yeah, no, there's plenty of bugs out there for them to eat. They're doing a good job, but also they sometimes run into humans. And so,
Yeah.
it's just a regular summer, I guess.
Now, are there people being bit by the bats, or they're just,
Yes.
they
They're
are
exposed enough,
to where we think?
yeah,
they are?
that we
Wow.
think it's probably in line to go ahead and do the rabies series.
Okay,
Yeah.
yeah, that's pretty serious.
Sarah Project, I just have a brief mention. One of the groups that we have met with prior to implementation and that we will continue to meet with post go live for every 2 weeks for an entire year, so up until next June, is our regulatory group. And so some of the things that we are monitoring with this group is how well we're doing in our promoting interoperability. So we're looking at how often the doctors are going in to see a cures report before they prescribe medications, et cetera, et cetera. And so far, we're doing really well. They say we're doing better than they expected on some of these
Good.
things, but so and we haven't even gotten into, as we talked briefly with these doctors today, we haven't even gotten into our health check yet, or our running reports and that sort of thing. So as we get more into that at the beginning of August, I think I'll be coming to you to see what kind of things do you want to see us reporting on that we can pull.
And the health check, when you say health check, what is that?
I can explain that. So the health check is the systems. So what we do, they call it a health check. And basically what it amounts to is that there's enough data now in the system. It takes a few months. And we have enough data to actually populate reports that actually make sense. There's a high enough N number.
Okay, yeah.
So we can actually start doing lights on reporting and some of our reporting. So their health check basically is the data's in there and we're able to yank it out. And then they
What
start
does the N
training.
number look like usually? Do you have any sense of that?
Our N number,
Yeah.
as many as we can shove in there. I don't know. I don't know if they're looking for an N number for validity, but they call it the health check, and the health check is to determine if there is in fact enough data to make sense of these reports.
Yeah.
And that
Otherwise,
usually
you
comes,
see a
what,
report,
3
there's like
months,
this,
TK?
there's like
3 months
62
after,
people in there.
90 days after go live? Kevin? What's that typically? And that's just kind of the same thing they throw up there. There's enough data in here now to actually start using our reports.
So it's not really.
It's not an N number.
Yeah.
No, it's just a time.
It's going to take us a while to have enough accumulation of, say, inpatients.
Yeah, because we've
Before
been
we
so
really
low.
study
our
it
census
to make
numbers.
it meaningful. But in the ER, you know, we're seeing significant volumes. It's summer months, and so it just depends on what do we want to look at. You know, I know what we looked at in my former facility as far as like the number of left without being seen, you know, and that sort of thing, and really drilling down. Why are we seeing that? We had a number, we wanted to keep it less than 2%. And so just looking at those KPI, the key performance indicators, and so there will be some areas of Seneca that will be able to really start drilling down on some things, and there will be other areas where it's going to take us a bit longer to get there.
Well, and I'm wondering if that might be a eventual opportunity too, to see, okay, during these months, if we have a larger proportion of people coming in for a specific reason, maybe it's a community education thing where we can.
That is exactly why we use that data.
Yes, yes. We can say, hey, you know, look out for X, Y, and Z,
Yep.
so you don't end up in our ER.
These data will be used for putting out public announcements.
Mhm.
These data will be used for knowing how to flex up and flex down from a staffing ratio.
Yeah. And supplies.
We
Yeah.
can trend these data, we put them in pivot tables. So yeah, this can't
It's
wait
really
for
exciting.
data, you know,
Yeah.
where we see trending. You know, I've always said that healthcare is, you know, data rich and information poor. And we were really blind with CPSI. I'm talking, it was hard.
Yeah.
And now I'm hoping that this just provides us so much analytical information that we can really make good decisions.
Good, I like it.
And they're rich in resource for in some cases.
Yeah.
Yeah.
A little bit, yeah. As far as nursing recruitment and retention, I'm just giving you a little bit of background information. Our CNA program is going on. One of our Seneca LVNs who's been with us for quite a while, just passed her NCLEX. She's a Seneca RN now.
I
Congratulations.
wanted to ask you about
That's
that.
amazing.
I noticed you didn't put a name here, and it's made me start thinking, is there a way when we have these milestones for people that we can send a congratulations to them?
Oh, that's a great idea.
Wonderful.
The board, absolutely.
Yes.
Yeah.
I would love to do that, yes.
We can share a name.
Nice thought, for sure. And then she would really appreciate it because she's pretty proud of herself.
Well,
of
we're
her
proud
as
too.
well.
Heck yeah.
That's wonderful.
Kept
Yeah.
going.
And then we just hired a new grad LPN about 2 weeks ago, so he is in his orientation to the long-term care unit. And he's a good story too, because he actually was here with Casey Broussard. He did his senior project here. And so he was exposed to healthcare, and he loved it. He decided after that experience, he was going to become a nurse.
That's
And
wonderful.
He did, and so that's really, that's a great, you know, kind of grow your own.
That's a beautiful story. Yeah, I love that.
Sean mentioned we will be focusing as soon as Tessa gets back from Ireland next week. We were waiting for Steve's team to feel comfortable that we had all of our billing and everything in order. Now we've made so many changes. Our long-term care census currently is 12. And so we have 4 open beds, and so we're going to be really focused on repopulating our residents in there.
Very good.
Donna gave a great report on where we're at with, there's still a lot happening with the planning and of the new hospital. Even when she was giving that report, I felt exhausted. It was like, oh, we are doing all of that stuff. And then our regulatory updates, we did have a visit by the Board of Pharmacy, which we had anticipated because we needed to relicense our Pyxis medication dispensing machines. So we knew they were coming in, but once they're in, then they get to look at everything. And so we received their final report last week. And Holt and I met with our 2 pharmacists, and we're developing a plan of correction because some regulations have changed regarding drug rooms. And it will require us to have our pharmacists on site much more so than they currently are. It will change our workflows a bit because they no longer allow nurses to restock Pyxis units. It can be a pharmacy tech with a pharmacist there, or it can just be the pharmacist doing it solely on their own. So we're trying to solution this right now.
So a pharmacy tech with a pharmacist?
Yes.
So
It's gonna cost, basically, it's gonna cost
It's
us.
gonna cost us, yeah. So we are having 2 of our nurses, an LVN and an RN, are going to get certified as pharmacy techs so that they can assist the pharmacists. So hopefully we can expedite whatever we need to do that requires a pharmacist to be on site to limit the amount of hours.
So what's required for them to get licensed for that purpose?
It's actually something that one of our pharmacists can assist with. There's just a curriculum and then a final certification exam.
Okay.
So it's not huge, but it is a formalized process.
Will it take 6 months to
Probably 90 days.
90 days? Okay, okay. And then how frequently will we have to have the pharmacist come to restock, I guess?
Those are some of the things that we're working through.
Yeah, okay.
And so we will have to redefine our workflows related to ordering medications, when those medications arrive, how to store them,
So is
et
this for
cetera.
all medications that go in the Pyxis or just specific ones?
This is for all.
Wow, okay.
Well, there's also some new regulation coming around that's gonna affect EMS. So there's almost a chain of custody, call it global what?
The GLN, the global licensing number, so that when you are dispensing out of your drug room or what have you, that there's, just like you said, a chain of custody of exactly where those medications went. Currently, our process is Chester Fire comes in, they need a restock of a PAR level, or they need to replenish the medications they just used on cardiac arrest or what have you, and we go ahead and give them those. We do log it, we track it, but it isn't tied to a GLN.
And now they've got to track it to the patient.
Wow, okay.
So
When does that take effect?
November,
November?
a lot happening in November.
Yeah, there is.
Yeah.
Oh,
So more to come on that. We did have CDPH show up a couple weeks ago. That was on a self-reported fall in the long-term care unit. They, there were no findings. There, the patient was very well cared for and follow-up was done. But they are required to show up for any report that they received. And then we anticipate them arriving again soon, because we did have to report, we filed a report of misconduct on a traveler CNA because she abandoned her shift. And so we filed a report and they will be investigating that. And she was, of course, immediately terminated on the spot. And unless you have any questions, that's my report this month.
Board members, questions? Thank you, Judy, really appreciate it. All right, next up we have our departmental documents and reports, and it looks like we just have our HR report and our marketing reports for this month.
So you want to do a verbal IT report?
Yep. Yeah, if you could.
You made her use in messed up, I just wanted to tell you things. I'm scared to listen, because I'm going to tear out of me. I originally joined Seneca in 2010. We've come a long way over the last 13 years. I am so thankful for the many opportunities and growth. I'm thankful for the 2 amazing ladies I have had the privilege to work with in IT. Sarah Timmons and Candace Powell. They are dedicated, intelligent, highly adaptable, hardworking, and positive souls. Even though many days they are working to manage EMR frustrations while resolving functionality and balancing security. This move to Cerner was much needed from both clinical and business perspectives as we move into the 3rd month after go live. We are seeing stabilization while we work to maximize use and fine tune. The reporting is already showing benefits. I'm relieved to know that as I move away to new adventures, Brian Churchill will step in and carry on. His Cerner knowledge and hospital build experience is perfectly suited. I take with me many fond memories and sense of accomplishments as we are on our second year mark. Have faced staffing issues, pandemics, fires, blizzards, and more. I haven't seen the locusts yet.
I hear they're out that way.
Yeah. I don't know, I was kind of thinking the mosquitoes were kind of vicious
There's some
this year.
big caterpillars, I guess.
Oh, okay.
Yeah, that's what I'm talking about, yeah.
So we now have new business partners and we have a better business sense in an IT perspective that will enable us to serve this community for many years to come. I thank you, Sean, for your leadership, your energy, and your dedication to the community. Although miles away, I'm available to share any information, references, and other guidance as needed, as one of my goals has always been to ensure continuity of care for the community. I wish the district and the town good health, but I must say so long for now. Thank you.
Thank you.
If I could just add something, when I got here, we just had this conversation today. 3 years ago, I think that the board was brought to the board about our IT infrastructure, our exposure, how it was brought forward. And I just want to tell you that TK took it upon herself and worked with us, all of us. We now have an infrastructure that is state-of-the-art, secured, and is going to take us into whatever we can. I mean, we're writing Cerner on it. We've written all these applications running on an infrastructure now that doesn't break, is highly secure. So I want to thank TK because she was the spearhead on a lot of that work. So TK, thank you. We're way better place, way better place from a technology perspective than we were.
Thank you for your hard work and dedication. Thank you. We really do appreciate it. And best of luck. Where are you off to?
No, I
Okay.
have family up in Washington State.
Okay.
So I'm still using the benefits of both sides, both the technology and the nursing. I will be an intake and triage nurse for a home health hospice program that apparently is having issues with entering medications into the EMR. So I already have some
Dive right in.
tests waiting for me. But it's very exciting. They're a non-for-profit. So there will also be some fundraising involved, community outreach. So I'm really excited.
It's going to be a great outcome.
Sounds like a wonderful
Thank you,
move.
TK.
We'll miss you.
TK.
Thank
It's
you.
been awesome.
Appreciate it. All right. And with that, moving to our HR report from Corey. Anyone have any questions? I very much enjoyed Judy's focusing on the newsletter and the newsletter. And I don't think I had any, I also appreciated having the CNAs. I think we were missing one in our newsletter. And we have 3, but only 2, just as a matter of formatting, but yeah, I thought this was great. Anyone have any questions or comments on the HR report?
Nope.
Okay, thank you. Okay, moving on, then we have, well, no, it was in mine, marketing PR report. It's not in here, but I know I saw it. No, it's okay. I read it already. Do you guys have any questions, or Chelsea, do you want to kind of give us an overview? I think I see you unmuted, maybe.
Yeah, so I'm available to answer any question. It's been pretty busy planning the groundbreaking ceremony, but now that that's done, we're back on with all of the other projects. So working on some provider recruitment pages, lots of updates on the website. That's a constant. And then also we're now gearing up for all of our content that's printed that you have to get approved by August and September for next year. We're working on new radio ads. We're working on all the magazines, phone books, things like that. So because it's all due beginning of October. Some of it's due in August. So that's the next major project right now for me.
Hey, Chelsea, what is the Raven Light video that's going to be showing in the theaters?
Ravenlight Video in theaters is the video that it's all about Seneca. So it's a branding video, and it's Seneca cares for the community, and we're here. So it's the one we did through Ravenlight, and if you guys want, I can pull it up and play it real quick if you haven't seen it.
So Ravenlight is our video company that's going to be doing a lot of our promotion. Hopefully we don't have too much lag today.
Can she share her screen?
Yeah.
Yeah, give me a second. I'm pulling it up. I didn't have it pulled up, so hold on.
I think she was running through our agenda items as we were going, yeah.
It could be the WAP. It's our white list in this room. It's terrible.
Okay, so.
All right. Okay, I'm gonna try and share it, and we'll see what happens.
All right. Thank you.
It depends on how much use there is. But I have updates for you.
Our home is a thriving mountain community, which is why we're happy to be there when things aren't at their best. So you can keep on enjoying every moment. Seneca, caring for our community.
I've got an issue,
Yes.
and I've had this issue for many years. There are many people that don't know
Where we are.
Seneca means Chester Lake Almanor.
Right, that's the only thing I was gonna say.
I have a mug that was very nice, and it doesn't say anything about where Seneca Healthcare District is located. People know the town of Seneca. It's not near Chester. And I've had this problem for years. I've said it at many board meetings. When we're building a new hospital, I would like there be some mention of Chester Lake Almanor somewhere in the promotional materials. I'll tell you, at the country club with all the new people there, Seneca means nothing to them.
So Chelsea, I think that video is great. I think his suggestion is the ending where you.
We
support
we can add located in Chester Lake Almanor. That's not a problem. So it's going to play at our local theater, which those people will know Seneca, and it plays at Susanville theaters. So we can add it though. That's not a problem. That's super easy to do.
Located in Chester on the shores of Lake Almanor.
Well, we're not on the shores.
Here we are.
You hit a golf.
We're on the edge.
Not me, somebody did.
Yeah, but yeah, I think that's what.
No, I agree. We do need to be more, there needs to be more location related. Where are we?
Yeah, so I think Chelsea, maybe as you're developing our marketing materials going forward, if perhaps we could keep that in mind, just because to Rich's point, someone may not know where it is.
Definitely, we can make sure to keep that in mind.
Yeah, but I think the video's
The
great.
video is great. I don't mean to be critical of the video, but I'm just speaking on behalf of those that don't live in Chester, don't know there's a hospital in Chester.
Even some people who do live in Chester don't know there's a hospital in Chester
Hey, there's a hospital in Chester.
and a clinic.
Yeah,
Yeah, I was talking to someone the other day and they asked me
And
where it was.
You're
And I was
right.
trying to describe it to them and they're like, I only know 36. I don't know where you're talking about.
Main Street.
It's a fair point.
Yep, no, it is. So more focus on, we got to get exposure big time.
Yeah.
Okay. All right.
Thank you for
Thank
showing
you.
that, Chelsea. Do you guys have any questions for Chelsea around the rest of the marketing piece that she?
No, she should be congratulated for the groundbreaking.
Absolutely, yes.
That was a great program.
Yes, you did a wonderful job organizing and making sure we were all on track for that, Chelsea. Thank you. All right, so I guess moving on, we will adjourn to closed session.
Very good.
Oh,
You know-
serious. That was pretty, yeah.
You guys want a break or you just want to? You good?
Wrap up and go home.
Yeah, it's gone. Finished up.
Yeah.
My eyes will not quit watering.
Hmm. That's no good.
Yeah, I've been having that kind of problem.
Yeah.
All right, we are resuming open session. There were no reportable actions taken during closed session. Our next regular board meeting will be August 31st at 3 p.m. here in the conference room. Thank you all. Meeting adjourned.
Thank you all.
Nikki Payne, well, I appreciate you set that up. Okay, at least got here. And those were two heavy hitters.
Yeah.
CMO for Community Works and CMO for Millennium.